Well, welcome back to H360 Health Talk. As we know, November is Lung Cancer Awareness Month, and I'm here with Dr. Desai and Vivian from RWJ Barnabas Health in Hamilton, New Jersey. Guys, thank you for joining me.
Thank you.
Thank you for having us.
So going through the cancer journey, it helps to have a nurse navigator on the inside that can really point you to services and things that might be covered or delivered outside of the network in which you provide. Does that play a role in your institution as well?
Yes, definitely. And I'm not just a nurse practitioner, but I monitor the lung screening program, and also I'm the navigator as well. So yes, I work closely with the patient, the family, and the physicians in the community to get these patients in.
So you said something that caught my ear. You said the lung screening program, right? Mm-hmm. So what is that? Is that a community-based program where you go out and you're talking to people, building awareness? And is it a simple screen? Can it be performed by blowing into a tube? And I've seen it on a couple of shows. They blow in and the ball rises, and you try to keep the ball at a certain level to test your lung capacity. Is that what we're speaking of?
No. So now
okay. So much for Dr. House. All right.
So now there is a screening tool called low-dose CAT scan of the chest.
Okay.
That is now approved as the standardized testing for early detection of lung cancer, just like mammogram is for breast cancer. The low-dose CAT scan is now for lung cancer. And it's a yearly scan until you are age 80 or you've quit for more than 15 years. So whichever one comes first. And this scan is covered 100% by insurance if you meet the screening criteria.
Okay, so my friends in colon cancer tell me that on your 50th birthday, treat yourself to a colonoscopy, which I did, because I take every opportunity to get on my soapbox and talk about early detection can save your life, right? And we talk about breast cancer, and I always look in the camera and say, men, you have breasts too. So give yourself a breast exam when you're in the shower. If you feel a lump, you get it checked out sooner rather than later. So my friends in colon cancer tell me that if you have colon cancer in your family, if the standard is on your 50th birthday, you should get a colonoscopy. The rule of thumb, if it's in your family, is if, let's say, your father was diagnosed at 40, you should get your first colonoscopy 10 years earlier than that diagnosis, which would be 30 if it were me. Does something like that apply to lung cancer?
So with lung cancer, the screening criteria there's two screening criteria. So for Medicare, you have to be at least age 55 and must have at least 30 pack a year smoking history.
How much?
30 pack a year smoking history.
Wow.
So, 1 pack a day for 30 years, or 2 pack a day for 20 years, or 3 pack for 15 years will equal 30 pack a year history.
So, doctor, the different stages of lung cancer, I would imagine at the different stages there are different treatments, different diagnostics, different tools, medications, screenings that you're providing. Can you take me through, what that looks like at a high level for each one of the stages?
Sure. So the earliest stage would be stage 1. These are cancers that are only in the lung, have not spread to any lymph nodes or spread outside of a single lobe in the lung. Our lung is divided into 5 lobes, 3 on the right side, 2 on the left side. And so as long as the cancer is in one lobe and not spread anywhere else, that's called a stage 1. Treatment for that would be surgical resection. The patient would meet with a thoracic surgeon and would undergo a surgery called video-assisted thoracoscopic surgery. They would cut out that lobe of the lung, and sometimes they would remove some of the lymph nodes nearby just to test them. Stage 2 lung cancers have gone to lymph nodes that are within the lung itself, and those those lymph nodes would anyway have come out during the surgery that I just described. But if they have been in those lymph nodes, it becomes a stage 2, which is a little bit higher risk, and therefore, after surgery, we'll typically treat the patients with some form of chemotherapy to try to reduce the risk of it coming back in the future. Then stage 3 lung cancers, which unfortunately are probably the majority of the patients, stage 3 and stage 4, those cancers are spread to lymph nodes that are between the two lungs in the middle of the chest. And those cancers need more than just surgery. And typically we don't even start with surgery. We will first have the patient see a medical oncologist and a radiation oncologist. And the radiation doctor will give them radiation treatments, which are kind of high energy x-rays that are pointed at the middle of the chest and the lung.
Is that to try to reduce the tumor?
Those are to kill those cancer cells that it's pointing to. And there's all different machines, and the techniques they're using now are there's a type of radiation called Imrt, and that is they're able to kind of limit the amount of good tissue that gets the radiation and just try to localize it to only the bad tissue, the cancer. And so that might be given for a course of about 6 weeks, along with chemotherapy. And the chemotherapy will be given weekly during the radiation treatments. And then typically after the radiation is finished and the chemo's finished, we might give the patient some immunotherapy to kind of, again, kill any cells that might have been that left that area beforehand.
Do you participate in any clinical studies? So bringing new therapies to market, and how do you determine? And do you discuss openly with your patients that you might be right for a new study?
We have many clinical trials that are open through the Cancer Institute of New Jersey. They probably have 30 or 40 different clinical trials that are ongoing in different types of cancers. But yes, if it's a trial that we have open in Hamilton, we will offer to the patients. In fact, Vivian and some of our research coordinators there are very proactive about making sure that we know about a trial that might be available to each patient. So they look through the list every day of all the patients who are being seen, and they connect us to this trial is available for this patient, so we don't forget.
So I want to debunk a myth about clinical trials. So some patients have said, well, why would I want to enroll in a clinical trial when I have a possibility of getting a placebo, which is a sugar pill, and then my cancer will just continue to grow, and that'll be the end of it for me? But that's not the case, is it? You're either getting the drug that's being tested, or you're getting whatever today's standard of care is for that type of patient. Is that correct?
That's correct, yes. I mean, no, the only trials that will have a placebo are ones where there is no standard of care left over. So you might, if you've had all the standard treatments available to you, and now you are at a point where there's no options left for you, and we have a new drug that is already gone through early phases, so they've been tested in patients that we know it's safe, and now we're trying to figure out, is this something we should approve? That might be the only time you're looking at a placebo, what we call a placebo-controlled trial.
So doctor, you said you used a word that caught my attention earlier, immunotherapy, depending on how you pronounce it. And I don't think a lot of patients, certainly, that I've talked to, know what that term even is. And it seems to be new, and it seems like all the innovation, especially around lung cancer, I hear that word being thrown around, and a lot of money and research and development and clinical studies. What exactly is immunotherapy, and how does that work? And do you see promise in that type of medicine?
So immunotherapy are a new class of drugs that harness the patient's immune system. So far, the main class has been a drug we call checkpoint inhibitors. And there's a pathway in the immune system called the checkpoint pathway. And these drugs block that checkpoint. And essentially, the checkpoint is a break on a patient's immune system. We have a natural break, so that if you start getting an infection, your immune system starts up to attack that bacteria or virus, but then at some point you want to stop that immune attack, and so you have this pathway called checkpoint, and that stops it. It's the brakes of your immune system. So these new drugs were developed that block the checkpoint pathway, and so the immune system essentially stays on for a prolonged period of time. And these drugs were first tested in a cancer called melanoma. It's a type of skin cancer, and they found that in certain percentage of patients were responding to it. If these were patients whose melanoma spread to other parts of their body, and they were responding to it. And then slowly they found that it works in kidney cancer, lung cancer, and now it's, I think, about 7 or 8 different types of cancer are responding to immunotherapies. It's not everyone who's responding, and we have a test called PD-L1, which is a test that's on the tumor itself. You look for how much PD-L1 is expressed on the tumor cells, and the higher the percentages, the higher the likelihood is that the person will respond. But you could have your 1% of PD-L1 on your cancer cells, and you may respond, and you might have 99% and you may not respond. These are just numbers, but nowadays, essentially anyone who has at least 1% of PD-L1 expression on their tumor cells, they're allowed to get immunotherapy, and if they have 0%, then they're allowed to get immunotherapy as long as it's combined with chemotherapy. They're not allowed to get it by.
So, Vivian, November being Lung Cancer Awareness Month, are there programs that you guys have that are special during that month for patients or the community?
Yes, we do a lot of community outreach education. We also offer tobacco cessation services as well to the community and also on campus.
Mm-hmm.
And we actually this year we actually going to have a tobacco exchange program where patients who smoke comes in, they turn in their cigarette, and they get a free patch and free counseling as well.
So what does the patch actually do? Is it a slow release of nicotine into the system so that they're not getting nicotine through inhaling?
Yeah, so the patch typically releases like a 0.4 milligram of nicotine in the blood system to take their urge off.
Mm. So, and then if somebody makes the decision that they're going to kick the habit, so to speak, do they start off with, one dose of patch, and then as they progress along, it lowers until there's no more patch?
So the patch comes in 21 milligram, 14 milligram, and 7 milligram. So the dosage depends on how much the person smokes. Mm-hmm. So for instance, if someone tells me they smoke a pack a day, then that person will receive 21 milligram patch. And as they taper off, then the doses also goes down.
Well, Lung Cancer Awareness, November. We have a lot of work to do. We discussed that. 200,000+ new cases every year. But what gives me hope is that there are people like you and institutions like Robert Wood Johnson Barnabas Hospital in Hamilton, New Jersey, to help build awareness and provide the all-important care that you guys provide to patients, their caregivers, and their families. So thank you for coming in and helping me shine the spotlight on lung cancer. And I hope to see you back at this table for another discussion in the near future.
Thank you so much, Dave.
Thank you for having us.